Thank you very much for the introduction. Thanks for having me here. Going ahead with the presentation. So as Dimitri mentioned, this is an overview. This talk will be an overview of the paper that we published earlier this year in Circulation, with some of the definitions for studies and trials in the CTO PCI field, the Chronic Total Occlusion Academic Research Consortium. Of course, this was a collective endeavor, so I want to thanks everybody involved. And so the CTO work was divided in 3 different sections: the key anatomic and procedural aspects, efficacy and safety endpoints, and the clinical trial design principles. And we're going to talk briefly a little bit on all of them. So we first need to define what is a CTO. Important here is to understand what is a CTO with typical appearance, so trials can compare apples to apples. I would like to highlight how 2 CTOs divided by an island should be measured, from the proximal cap of the proximal CTO to the distal cap of the distal CTO. And here I'm going to show you an example of such a case. We have 2 CTOs in the LAD measuring 6 millimeters and 13 millimeters, and if you combine them, it's going to end up with a CTO of 27 millimeters. We all know that 2 CTOs in the same vessel are usually one of the most difficult scenarios that we can face between a CTO PCI. So it would not be fair to compare 2 CTOs, short CTOs, with a single CTO in studies or registries. Another interesting aspect, and that generated a lot of debate, was the nomenclature for the vessel architecture. One needs to realize that the subintimal space is not really an accurate term for where our equipment is. And because of that, it was decided that we should use a more precise term known as extraplaque or intraplaque. Although the terms true and false lumen can still be used, but for segments before and after the CTO. Lesion crossing strategies were also defined. To mention here, we're not using the term escalation anymore when talking about wiring, either antegrade or retrograde, because as we all know, we tend to escalate, de-escalate, escalate again during antegrade, during wiring, antegrade or retrograde. So we moved away from the escalation main. It's also based on intention. It's not the real position of the wire. So it's all about, if you want to talk about real position, you need to do the intravascular imaging. And there are several other definitions on CTO devices and equipment, collateral channels, and some other lesion characteristics and complexity scores, and encourage you all to take a look at the manuscript published in the Circulation to get more definitions on those aspects. Talking about endpoints, it's interesting here. So we start with the crossing success, and which could be either antegrade, retrograde, or just crossing the collateral. Once you achieve the crossing success, then you're aiming for the technical success, which would be a TIMI flow equal or greater than 2. If we remember the live case, one of the live cases, there was a debate if we had the TIMI 3 flow and whether it's a success or not. So the consensus of the CTO work was that because of the collaterals we have, not always we are able to achieve a TIMI 3. So it would be, although we have all the good features of successful intervention, not having a TIMI 3 flow would be unfair to the procedure. This still need to be proven and in ongoing future studies. Also need to achieve revascularization of all distal branches equal or greater than 2.5 that's a complete technical success. If not all, then it's a partial technical success, and also residual stenosis less than 30%. And to achieve a procedural success, we'd have a technical success in the absence of in-hospital MACE, again, complete or partial, depending on the achievement of revascularization of distal branches. If you're studying devices, then you would choose a specific criteria for a specific device, whether it would be a crossing success for wires, for instance, or technical or procedure if you're assessing drug-eluting balloons or drug-eluting stents. When talking about these endpoints, death, stroke, bleeding, non-procedural MIs, those were really straightforward. But on the other hand, defining procedural MI specifically after the Excel trial wasn't that easy. So we decided to endorse the SKY definition, but also collecting all data so other definitions could be used as secondary endpoints. The procedures presented here are part of the initial therapeutic strategy if performed in scheduled fashion and should not be considered adverse events. The time limit of which should be well documented in the chart. If a patient comes earlier than planned due to ongoing chest pain, for instance, that is considered an unplanned procedure and therefore a MACE. So just going briefly, we have a pre-index procedure where usually you treat non-CTO lesions, the index procedure, then the second index procedure. You might ask, why not the third? Because at some point we need to stop, otherwise you get a third, a fourth, a fifth. Then post-index procedure, a stage procedure to treat again non-CTO lesions, and we are allowed for optimization procedure to bring back the patient and optimize the final result we got in our intervention. With unplanned repeat revascularization, I'd like to highlight here the CTO-related non-TBR, which is a new classification for which is a new lesion in instrumented non-target vessel within a month after the index procedure. And there are several other endpoints. Again, I encourage everybody going to the main paper to take a look at this. Just highlighting the silent stent thrombosis, which is an occlusion that occurs with no clinical sequela, in other words, MI, TBR, or death, and usually is an incidental finding of follow-up angiography. On clinical design principles, which I find the most interesting part of this paper, there's a lot of discussion about the inclusion criteria for CTO trials. Of course, it's going to depend on the population and objective of the trial. You have multiple that you could choose on. And so if you're assessing quality of life, if you're assessing MACE, if you're functional, change in ischemia, change in ejection fraction, you're going to choose your inclusion and criteria accordingly. And the same for follow-up. If you're assessing quality of life or functional outcomes, 3 months is okay, but if you're assessing durability or MACE, you'd want a higher, longer follow-up. In conclusion, uniform consensus definitions of cross studies provides greater consistency, more information and insights into comparative health outcomes. And it's important to say that the CTO work is by its nature dynamic and will doubtless be updated in the future. Once again, thank you very much for the kind attention and for having me here.
Thank you, Dr. Dimitri.